Hello, I'm Jackie Glover, a philosopher ethicist in the Department of Pediatrics and the Center for Bioethics and Humanities. On behalf of the Center for Bioethics and Humanities and the Ethics Committee at the University Hospital, I'd like to thank you all for viewing and responding to our Zoom ethics grand rounds in April. I'm going to start by sharing some highlights of your responses, and then I'm going to interview Dr. Wynia based on your questions. Slides, please. Thank you so much to Dr. Wynia and Dr. Kao for the wonderful interview that you all viewed and for your responses. Next screen. So here's who participated: nurses, physicians, social workers, chaplains, one patient, and others. And here are the top issues. First, by a long shot, the protection of healthcare workers, then allocation of resources in triage, and then protection of patients. Next slide. And we asked you, what is working for you in this troubling time? And so these are the things that you responded: maintaining a healthy balance between being informed and being overwhelmed, staying connected with friends and families, helping others, do some kind of physical activity, exercise, tap into your creative side, talk to your coworkers and teammates, process your feelings, fears, share positive success stories, discuss what's working and what you might do differently. Do some spiritual self-care, meditation, online church services, devotionals, breathing exercise, journaling, a gratitude list, and finally, take advantage of the mental health resources available through your employers and community groups. All really good tips for self-care. So now, Dr. Wynia, our first question is kind of two parts. Who is going to make decisions regarding critical support, like ventilators, if there is a shortage? And the second part, are there people with ethics backgrounds involved in the system level conversation about this allocation?
Yeah, thank you. So first of all, Jackie, I just want to say thank you for making a virtual asynchronous grand rounds. I think this is a wonderful idea, and I expect it's going to catch on. The idea that you can sort of post it, people can watch it at their own time, send in questions, and then have an opportunity to talk later it was a brilliant idea. So I appreciate the opportunity to do this experiment. So the answer, I'll take the second part first because that's easy. The answer is yes, there are ethics people involved at the system level, at university health system, and if you think about this nationally, there are ethicists involved at every level of conversation right now around the country looking at these issues. And then the first part was, who actually would make decisions? And that's a terrific question because I think it actually reflects one of the areas where there is wide agreement across systems and across states, and that is you do not want the individual doctor, the team at the bedside, being essentially burdened with having to choose between their own patients, which one gets a scarce resource and which one does not. And there are a variety of reasons for that, but the two big ones are you would like the bedside care team to be able to preserve their role as the advocate for that patient, for each of their patients. And secondly, the people at the bedside really can't have, in the midst of a busy clinical service, they can't have the situational awareness necessary to make good allocation decisions. The last thing anyone would want is that someone at a hospital or on one floor says, I'm sorry, we are not going to be able to give you this because there are none available. And it turns out that there was something available, but it was just, a few floors away or a few blocks away or even a few miles away at a different hospital. So the team that makes the triage decision really has to have excellent and broad situational awareness so that we do not ever resort to making triage decisions that were not actually necessary.
Second question, will healthcare workers be given priority if resources become scarce?
So in the Colorado Crisis Standards of Care Plan, which has been adopted by the governor's review committee on this, but I should hasten to say has not been implemented. So this is a plan to be implemented if we get to a point where we actually need to be doing triage, and we're not there yet as regards ventilators and hospital services. But in the Colorado plan, healthcare workers, including frontline workers of all sorts, as well as other emergency responders and sort of first line responders, are given a slight priority if there is a tie in their clinical prognosis. So if you have 3 or 4 or 5 people, all of whom might benefit from being on a ventilator, and there's only 1 or 2 ventilators left, you would look first at which of those people has the most chance of benefit, which of them is the most likely to pass away if they don't get it and survive if they do. And that's a clinical decision that doesn't have anything to do with whether you're a healthcare worker or anything else. It has to do with clinical parameters. And that's the primary consideration, is who needs this the most and will benefit from it the greatest. Second to that, if you had 2 people at the end of that consideration who were equally positioned to derive benefit, and one of them is a frontline worker, who maybe caught the disease while providing healthcare services, that person might then get the leg up over someone who was not. And it's a matter essentially of trying to preserve our healthcare workforce. And what's sometimes called the multiplier effect. The idea that if you can get that person well and bring them back into the fight, this is a term that comes from the military triage arena. If you can get that soldier back into the fight, that person may end up saving other lives. So that's the thinking behind giving some preference to people who are on the front lines. The other piece of that, by the way, is the idea that if you're taking your life in your hands on the front lines, that like soldiers in other arenas, if you get injured in battle, we give you health care for the rest of your life. That's a reciprocity argument, essentially, that you put your life on the line, and therefore we owe you something special for having been willing to do that.
So this is a question very associated with that first question. What are your thoughts about frontline staff refusing to care for patients if they don't have appropriate PPE?
Yeah, so this is a very individualized decision. My sense is that we all as health professionals have signed on to a job that we know sometimes carries risk, and that is just part of the job. It's by the way, as I think I mentioned in the interview with Audie Kao, it's a well-known piece of what it means to be a health professional. So it's not like we didn't realize that there could be a pandemic. I mean, we're in healthcare. We know there are pandemics. And so the fact that we have some obligation is undeniable. The questions arise around, well, to what extent does that obligation require us to take on really extraordinary risk? And I think for some of us, if you're otherwise healthy, the risk is pretty understandable. And I probably wouldn't walk into a room with no protection, but we have, fairly good studies suggesting that at least with influenza, if the person with influenza and the health professional are both at least wearing a surgical mask, that's actually pretty good protection. It's not perfect. And I think one of the things that really we need to acknowledge is that we are already today making some sacrifices in terms of personal protective equipment and safety, because the alternative, if we were to continue with business as usual, is to run out of personal protective equipment. And that would be much worse. So the fact that it's an acceptable thing to do today, the reason it's acceptable is not because it's perfectly safe and as good as what we normally do. It's not. It's not as safe. It's not as good as what we normally do, but it is good enough in comparison to the alternative, which is not providing people care or providing people care in our usual way and ending up running out of personal protective equipment entirely. So we're getting, a lot of guidance, and that guidance is shifting over time. And that's, unfortunately, that is to be expected in a dynamic environment like a disaster, where resources and what level of risk is acceptable are actually changing over time. And at the extreme, more risk is taken. And when we're not at that extreme, we shouldn't take that risk. And so as we get more PPE online, I expect that some of the things that the CDC now says in the current environment, it's okay to, reuse masks. It's okay to not use an N95 for certain types of interactions. Those are going to be pulled back when we have greater resource availability.
And there's widespread agreement that you don't have to do CPR until you have PPE on, even if it delays CPR.
Yeah, that is one of the areas where it's been very widely agreed. All of the professional societies have said the same thing. I think maybe people who don't know what CPR looks like and feels like may not realize CPR is an aerosol generating procedure. It creates not just spittle and droplets, it creates an aerosol of virus which permeates the entire room. So it's quite a dangerous procedure for people in the room if they're not wearing adequate protection.
As we shift away from individual patient autonomy to public health ethics, what is the role of advanced directives and advanced care planning in the triage of care setting?
Yeah, that's such a difficult and important question. On the one hand, there's a lot that we are supposed to be doing every day and that shouldn't really change, but is certainly getting more emphasis now. So for example, we're supposed to be asking people about their advanced directives and their preferences and values when anyone is admitted to the hospital. That sometimes has been neglected in the past. Today, I think everyone understands how critically important it is. We've seen people with COVID who really crash in just a very short period of time and look pretty healthy, and then they just really go downhill fast, and all of a sudden they can't talk anymore. And if you have failed to have that conversation in advance, that's a major problem, because the last thing we want to do in a shortage situation, but also in any situation, is put someone on a ventilator who would have said, no, never, don't do that to me, right? So I think that's something we should be doing all the time, and it's especially critical that we do it and do it well now. The more nuanced and difficult piece of this is I have now had several people send me emails saying, look, I've lived a good life. And of course, under normal circumstances, if I got pneumonia, I would probably want to be put on a ventilator to see if I could pull through it. But if there's a shortage, I would give that up to someone who maybe is younger or maybe who could use the ventilator better than I, who's got a whole life in front of them. And that altruistic impulse, it is something to be celebrated, certainly. It is certainly a really important component of a cohesive community. So we should be grateful that people have that altruistic impulse. And if someone said that, I'd be willing to go to the back of the line in a situation where there's a tremendous shortage. I think we ought to honor that. The question is, how can you ask people that question without it being coercive, without people knowing, are you asking, without people thinking, really, are you asking me, do I have a duty to die because I'm older now? And there is no perfect answer to that, because the people who object to even raising the question are right, that raising the question on its own could be somewhat coercive and might lead people to start thinking, well, I know what you think the right answer is. On the other hand, if you fail to ask that question, you are not giving that person an opportunity to demonstrate who they really are and who they really would be under those circumstances. So I think, this is something that people on our campus are doing research on right now, trying to figure out, are there ways to ask that question in a non-coercive way, in a way that is legitimately open and saying, you know, people think about this in a variety of different ways. Some people say, you know, I want it no matter what, please keep me alive as long as you can. Others think I wouldn't want it no matter what. You know, I've never thought I would want to be put on a ventilator. Don't do that. And there are people in the middle who say, well, I might want it, but if there's a lineup for it, I would be okay with being at the back of the line. And, you know, people range across that spectrum. Where do you see yourself in that spectrum? And that's, I think, one way potentially to bring this up, and we'll see. But I see that as a real ethical conundrum. Talk about that.
Yeah, speaking of research, we are a research endeavor at our hospital. What guidance can you offer for balancing continuing clinical trials with protecting patients from COVID-19?
Yeah, you know, this relates to a lot of things beyond research, right? That question could also be about what about people who have elective surgeries that have been postponed?
Mm-hmm.
And at what point do you say that that postponement of that elective surgery becomes dangerous? And in fact, that person ought to come in now to get that elective surgery, or, you know, the treatment for cancer that, you know, maybe can be deferred for a little while, but can't be deferred forever. And I think the same is true of research. Research deferred sometimes can be okay for a little while. Research deferred for a long time, you know, will delay in a very significant way findings that might have helped. And I think that's going to go into the bucket of what do we need to consider as we start to reopen, as we get the pandemic curve down to a level where we can actually do contact tracing again, where we can actually do testing again, where we have the capacity to do testing again. So as we come down to a level where we can start to gradually reopen, I think we are going to go through a process of triage again, decide which research protocols ought to be restarted now, which ones are the highest priority for restarting early, which ones hold the lowest risk of reigniting the pandemic or of putting patients at risk of contracting the illness. Are there ways that we can do that safely? And I don't have an answer to that, only to say that that will be a triage protocol, because we will not suddenly open everything. It will not go back to normal in a week, right? We will gradually reopen, and that means we're going to have to decide, you know, when to reopen different aspects of society, different aspects of the hospital, of the research enterprise, and so on.
So I'll refer our audience to May 14th Ethics Grand Rounds, which is on this topic, ethical issues in COVID research. So join us May 14th for a Zoom presentation. I'm going to jump ahead to a related question. What are the ethical principles that should guide reopening of society, since you mentioned that?
Well, I don't have, sorry, my phone is ringing. I don't have the one principle that guides that. I think it is, though, it's the same principles that guide triage in other contexts, right? It's what are the risks, what are the benefits, who are the stakeholders involved, and how are they affected by this discussion. And then you should have a process for making those decisions that is transparent, that's inclusive, that pays attention to equity, that pays attention to issues around who is being disadvantaged most by the closures, and who needs most to have things start to reopen. So I think each individual decision can go through that kind of a decisional process, and ought to be, you know, amenable to some accountability mechanisms to make decisions about that. I could easily imagine using some of the same thinking that we've put into the ventilator triage protocols here, where you say, well, it's probably not the teachers who should decide when to reopen the schools. Probably ought to be an independent body that looks at that. And that, of course, is what our public health system is for, is to say, okay, now the data support that the balance of harm, potential harms to children and their families, and the potential benefits are weighing it such that it's okay to start reopening schools. And can we do that in a phased way? So I think we will see many of the same principles related to proportionality, related to equity, related to transparency, inclusion. I think all of those will come into play as we start to reopen.
You know, everyone involved hopes we never have to use our triage program, but what efforts are being made to address the concerns of healthcare workers and the general public about these rationing decisions?
Yeah, so we, as people will know by now, because the Colorado protocol was published last week. So in the intervening time between when this aired and today, we've put out draft, what we called 0.9. And the reason we called it 0.9, version 0.9, is because we knew at the outset that we had to put this together for COVID so quickly that it undoubtedly would need to be improved. And there is already a set of revisions that are moving forward to the GERC, the Governor's Commission on this, over the next few days, to say, here are things we've heard back from various communities and that we feel need to be addressed in these protocols. And I don't think that's the end of it, right? So what's happening right now is transparency. It is openness and revisions based on the feedback that we're getting. And I think that will be ongoing. And God forbid we ever actually had to implement this. There would be additional rounds of revision and learning as we figured out what works and what doesn't work, and are there people being disadvantaged unfairly? And if so, how do we accommodate that and learn to make the system better? So I think the publicity around this is how we are doing transparency right now. That's how we are engaging the broader public. There was, by the way, a very broad group of people involved in developing the state guidance, and it was widely circulated in advance of becoming, really public. So I think it was a quite open process, considering that it took place over, 2 weeks. And beyond that, of course, now that it's in the newspapers and on the radio and so on, we're getting additional feedback. And there's teams of people who are incorporating that feedback and building it into the subsequent iterations.
So Dr. Wynia, in recent weeks, you've been thrust into the spotlight as an expert voice on pandemic ethics in the national media. In several recent webinars, you've said that as a society, we would have to reach back to World War II to find another event that changed the way the world thinks, lives, and practices healthcare on such a large scale. How do you think these recent experiences will influence the way you practice as a physician and as an ethicist? And what's one change to healthcare that you see as a result of this pandemic?
Well, first of all, this could actually be a relatively short answer, but I first want to give credit to my son, because it was he and I batting around. So thinking back, he's a college senior and very interested in history. And I was asking, what do you think is the last time that, and this is from the perspective of a 22-year-old, and he said it has to be World War II. Is the last time that there was this level of worldwide disruption and devastation. And I think he's right. I think even though things like 9/11 were tremendously influential worldwide, we are, currently losing the number of people who died on 9/11 every couple days. Just in the US, and around the world, of course, it's much more, much higher numbers. If we did nothing about this, if we did not practice the kind of physical distancing that we're doing right now, and we ended up with as many people catching COVID-19 as caught the H1N1 flu in 2009, we would have 60 million Americans with COVID-19. And at the best estimates, that gives us about 600,000 people dead. So we've been forced to make these decisions as a community. And we've made those decisions in largely voluntary ways where communities have really come together and decided that this is what we need to do to protect ourselves. And I don't know how that's going to affect things, but I will say it's quite amazing. And I'll just give you one quick example of the level of collaboration and cooperation that has arisen out of this, and that may move on into the future depending on how things play out. 6 weeks ago, there is a standing resource bank for the state where hospitals and health systems are supposed to send in how many ventilators they have and how many people are on ventilators and how many ICU beds they have and so on. And only about 45% of hospitals were reporting into that bank before COVID. And that bank's been around for a long time. And it's supposed to facilitate transfers between institutions, which we do all the time. But people didn't want to give up this information. It's proprietary information, essentially. How full is your ICU? How many ventilators do you have available? So for a variety of reasons, people didn't want to give that information up or didn't get around to it. Today, that data bank is 95% full. Everyone is reporting. Everyone is cooperating. They're in the development of these protocols for triage. Every health system is involved. And everyone recognizes that the last thing you would ever want to do is tell someone at one system, we don't have a ventilator for you, when there was a ventilator at a different health system just a few miles away. So we have to learn, and we have learned very quickly, how to drop our competitive barriers and cooperate. And that's an extraordinary thing that will have long-term implications. And we recognize this in disasters often, right? People come together in disasters. They create relationships in disasters that are incredibly strong and sometimes last for many, many years. Disaster response is a type of activity that is, there's a reason why military metaphors get used so often. It is a bonding experience, and going through a disaster together is a bonding experience for many communities. So I think those things are going to go on. And then the last question is, how does this change medicine? One way, and there's an obvious answer, telemedicine. Mm-hmm. There were innumerable barriers that absolutely prevented us from really doing telemedicine. And within 10 days, they all disappeared because they weren't real barriers. They were socially constructed barriers, right? They were regulatory, payment, and it turned out when push came to shove, we could drop that and figure out how to do telemedicine pretty well. And I'll be very surprised if we go back to the old way of doing things, because patients and doctors are learning that telemedicine works pretty well for many things. Doesn't work for everything, but we're figuring that out also. And the idea that, people have to give up half a day of work to go visit the doctor for an upper respiratory infection is just, that's gone. That I think already that's in the past.
So what's one question, to give you the last word, what's one question that we should have asked you?
Well, I'll tell you the thing I'm worried about in terms of the conversation about ventilator triage, and that is sometimes in the conversations about ventilator triage, there's sort of an underlying assumption that this is going to be life or death, that this is choosing who lives and who dies, and the person who doesn't get the ventilator will die, and the person who does get the ventilator will live. And I think we need to question that assumption. It may be that the person who doesn't get the ventilator will go on to pass away, but there's already research and some preliminary evidence that we may be intubating people too early and too aggressively. So it's very possible that how we treat this will change over time. And number two, much more depressing, at the very best, people who need to be intubated because they have COVID-19 have about a 50-50 chance of making it in the US so far. And in other places, in China, there are several studies where 85-90% of people who were intubated didn't make it. So I think the fact that you're getting a ventilator does not mean you're going to make it. And it may even be that the fact that you are triaged away from a ventilator doesn't mean you might not make it. So I think it's very important for us to think through these triage protocols and to do them as carefully and as thoughtfully with the best ethics that we can muster. And it's also important for us to be humble about the decision-making process. And it may be that we go through a very cautious and careful and thoughtful triage protocol, and it still doesn't actually make that much of a difference for the vast majority of patients.
Well, thank you, Dr. Wynia. Thank you to Julie Sweeney, the co-chair of the Ethics Committee, and to our center staff, David Weil and Malia Himber, to make this possible. Thank you for the 108 participants to make this so vital and possible. And we'll see you all on May 14th for ethical issues in COVID research. Thank you.